care to those who need it the most. An earthquake devastates a country, leaving hundreds of thousands in need of immediate medical care. A violent conflict sends civilians fleeing for their lives, with nowhere to go for help. A young woman lacks access to basic obstetric care, placing her at risk of dying from complications during childbirth. Whether it's a high-profile emergency or a forgotten crisis in a remote region, Doctors Without Borders teams are working tirelessly every day in nearly 70 countries around the world. We're primarily funded by donations from individuals like you, which allows us to make decisions independently and primarily on medical needs. So our only priority is to be present and effective wherever the medical and humanitarian needs are the greatest. On any given day, there are tens of thousands of local and international staff working tirelessly to deliver essential care to people who need it the most. Working for Doctors Without Borders is not an average 9-to-5 job. When an emergency strikes, we go where we're needed, when we're needed. When you work for Doctors Without Borders, you're working toward the goal of alleviating human suffering. You can make the real difference in someone's life. Thank you so much for watching MSF Pulse. This is our bi-weekly news show where we unpackage the humanitarian world. If you think that you have what it takes to work with us, please follow the link in the video description.
Hi everybody. Bonjour à tout le monde. Welcome to our event, Medical Ethics, MSF's Duty of Care. And it's appropriate that this is happening on World Humanitarian Day, so happy Humanitarian Day to everybody. My name is Saleem Kassam, and I'm a cardiologist working in Toronto, and I'm a board member with Médecins Sans Frontières Canada, Doctors Without Borders Canada. And I'm joined today by a great panel, including Lindsay Bryson, who's teleporting herself in from Stockholm. She's a registered nurse and is currently the Medical Innovation Advisor with MSF Sweden and holds a master's degree in biomedical ethics. And we have Jaime Wah, who is in the remote corners of Windsor, the hotspot in Canada for COVID at the moment. And she's a registered nurse and a field worker with significant experience and the medical lead for MSF's Canadian COVID-19 response team. And we're going to talk a bit more about MSF's medical ethics and how they guide our work. Doctors Without Borders, Médecins Sans Frontières, is an international Nobel Prize-winning medical humanitarian organization. And we provide emergency medical care to people affected by disaster, conflict, epidemics, and those excluded from healthcare. Our medical ethics guide us to provide high-quality care and to act always in the best interests of patients, to respect their confidentiality, their right to make their own decisions, and above all, to do them no harm. You know, as a medical doctor, we take medical ethics and its principles for granted, but they do impact so much of what we do on a day-to-day basis, whether it is discussing care with the patient, making sure they're informed about all the decisions they can possibly take, whether it is being sure that we respect their confidentiality and the privacy of their healthcare situation, or whether it's being sure that we always have their best interests at heart, whether that is aligned with what we believe is best or whether it is unaligned. We have to represent them at all times. But it's a lot more than that in reality, and it affects so much of what we do here in Canada, but anywhere in the world. There are other layers that make the principles of ethics more complex and require much more thought. And today we're going to try and deconstruct some of that. In addition to these medical ethics that we talked about, at the core of our identity at MSF is a strong commitment to humanitarian principles of independence, neutrality, and impartiality. Independence means that MSF relies on private donations, mainly from individual members of the public. This means our financial independence will allow us to provide aid based on our medical assessments, independent of any political pressure or anyone else's agenda. Impartiality means that we offer free medical care to people who need it. The emphasis being on need, not on anything else. No matter which country they're from, which religion they follow, or their political situation or affiliation, all that matters is they're human beings in need. And neutrality means that we don't take sides in any conflict situation or in any other situation where there are two sides to a perspective. We focus on saving lives and alleviating suffering where people's medical needs are greatest. These principles allow us to gain trust and acceptance, provide medical assistance in contexts where others are unable or unwilling to go. So welcome to those of you who are joining us just now. We're speaking today about MSF's medical ethics and how they guide our work. I'm going to reintroduce my panel, my star panel here. First of all, I'm Saleem Kassam, and I'm a member of the Doctors Without Borders MSF Canada Board of Directors. And I'm a cardiologist practicing in Toronto. I've worked with MSF since 1999 on several missions from Democratic Republic of Congo, Zambia, Kenya, and Haiti. And I've been on the board now. This is my 6th year. Today, we're going to speak about medical ethics and how they guide MSF's vital work. I'm joined by 2 other great panelists. We have Lindsay Bryson here, who is currently the medical advisor to MSF Sweden Innovation Unit and has a master's degree in health sciences and is specializing in biomedical ethics from the University of Toronto. Lindsay is a registered nurse and has worked with MSF since 2003 as a nurse in Congo-Brazzaville, Chad, Somalia, and Democratic Republic of Congo. She's been a medical coordinator in the Central African Republic, Haiti, DRC, and Ethiopia. That's a mouthful. Lindsay also has been involved in a wide range of projects relating to MSF's medical operations. So welcome, Lindsay. Thank you for joining us today. We also have Jaime Wah, who's a registered nurse and recently worked as the medical lead for our Canadian COVID-19 response team. Yay! Jaime is joining us from Windsor and has worked in multiple outbreak response situations such as Ebola in Sierra Leone, cholera in Yemen, and conflict-affected countries, including Central African Republic, Democratic Republic of Congo, and South Sudan. Great. So Lindsay, let's start with you. Tell us a bit about yourself and how medical ethics have guided your work in the field.
Well, thank you. Thanks for the introduction. I feel like there's not really much more for me to say. I mean, my background is in nursing. Joined MSF, as you said, in 2003. I've done multiple field assignments in many different contexts and been faced with many different challenges. And in fact, those challenges are what triggered me to go back and study ethics a little bit more deeply. I think maybe to start off, and less about how medical ethics really impacts my practice when I'm in the field, but to consider for the audience that sometimes the term medical ethics and ethics generally kind of, people get nervous around it, right? They feel like this is a really big thing, and it is, of course, they're guiding principles and they help support us. But as you said earlier, these are things that it just defines how we want to be treated, right? Being able to be autonomous in our decision making, knowing what's happening to us, knowing where we're going, and what all this is happening around us in any context. Having policies and procedures behind us that allow us to at least, if we're taking a really difficult decision, to do so transparently. Because I think at the end of the day, there is no perfectly right and perfectly wrong answer. This is a process, and we need to follow it. And then again, not doing any harm and doing good. These are, I think, for me, things that, regardless of my position as a nurse, as a humanitarian, I think these are something that we should be striving for in our daily lives, our regular lives, if you could call it that.
Great. Jaime, maybe you can provide us, building on what Lindsay just said, can you give us an example of where the sort of the issues around medical ethics and its principles have been important and have become brought to light in a specific situations you worked in?
Yeah, for example, I think I can clearly remember one of my first experiences with dealing with kind of these ethical questions for myself on the field. And my first assignment was in Central African Republic. And I remember I had this really sick child with malaria come into the hospital, and I was one of the nurses there. And we knew she was not doing very well, and she was not breathing very well on her own, and she had quite late stages of malaria. And so, we had the quick, decision and dilemma amongst our medical team on whether or not to intubate her, knowing that we didn't really have a generator running 24 hours a day. We don't have a ventilator. And we know that we don't have that manpower to ventilate her continuously for that prolonged period of time. And in Canada, working in the the healthcare system that we have in Canada, that would never be a question. We would automatically intubate, and we wouldn't have to question that at all. And then so having to kind of come from that and work in a resource limited setting and really kind of struggle with my own ethics and say, you know what, this is the reality here, and understand that, some really difficult choices have to be made in the field that are really quite unfair if you look at the grand scheme of things, and how this situation ended up in the first place. It's, political, there's a lot of other things happening, but then to bear witness and to say, we're part of Doctors Without Borders, we're here on the field, we're going to do the best we can, and even though it's not really enough, we're still going to be here to do as much as we can for the people that are there. So these decisions are not easy, especially when you have a life in your hands and you have to make those decisions on the ground. But yeah, and then kind of going back to what I'm doing here as the COVID lead in Canada, and kind of taking it at a larger scale and looking at decisions of why we were exploring COVID activities in Canada, in a country where, we have an advanced medical system in place. So kind of taking it from that angle and comparing it to other countries that don't have that advanced system, that don't have, a lot of ICU beds, a lot of ventilators. Why did we choose to kind of look at why are we exploring COVID operations in Canada? So yeah, that was also a lot of interesting discussions, and we discovered a lot of interesting things as well. Things like access to clean water is still an issue in Canada. Access to basic healthcare in some regions in Canada is still an issue. So these questions about what we're doing, why we're doing it, comes up time and time again, and I think these are really important questions that we have, all of us, to consider and to work through.
That's great, Jaime. It's remarkable that we've almost come full circle, because we talked about ventilators in a remote part of the world, and yet just a few months ago we were talking about ventilator scarcity in Italy and in the U.S. and in New York. So it's remarkable how this is really hit home for people who live in the Western world. Lindsay, maybe I'll ask you. There's a question that came to us earlier that relates to this, and it asks us about how scarce or costly supplies of equipment, whether that's PPE, personal protective equipment, or drugs or machines, are prioritized in the field. How do you approach that? How does MSF start to unpack that?
Well, I think I'll start my answer by saying that my current role I'm not involved in COVID response. So my answers will be drawn more from other experiences. But I think, while we say, you've got decision-making frameworks that are in place, and of course medical ethics play into this, but we can't take any of those decisions outside of the context. And I think Jaime's already spoken quite well to that you have to look at your context. So you're looking at your unmet medical needs, of course, you're looking at your humanitarian context, you're looking at all these different things. And then, unfortunately, I think in many cases, we're taking a very utilitarian approach, right? We're looking at how can we do the best with what we have in that current context. And in the example she gave in Central African Republic, they did their best with what they had in that moment. And I think when you're looking at how to divide up costly resources, it's, again, where will you have the most impact? For me, is quite an important point. And then you'll have, again, outside of COVID, we have more information on other diseases that we manage, and we know where we will be able to take care of the most people and really be able to improve their outcomes and decrease long-term morbidity. So I think those, for me, are sort of very important issues that we do tackle, but it comes down for me as really utilitarian, doing the best we can for the most people.
Yeah, and I think also, like, we talk about, these type of material resources and making sure that they're getting to where they're needed the most. But also, I think we're also, as MSF, very conscious about prevention, so that we're not only just focused on the curative treatment. We have a lot of our workers really involved in preventing disease and making sure that, really important public health messaging is available, and that is one of our biggest priorities, is to prevent the illness itself. So I really want to stress, like, yes, material resources is a huge question, and we always have to review that. But just as much as we focus on that, we really want to focus also on that preventative aspect, so that we don't kind of fall back into those material resources. If we can prevent anything, if it comes to COVID, we're talking about COVID, but we're also talking about any kind of communicable disease. There's a lot of prevention and a lot of hygiene and infection prevention control messaging that we're really, really involved with a lot of public health messaging in the community, and with public health workers and health workers, and especially at the community level. I think that's one of the most differences that we have, and I think it's a really important activity that we do, and that we really stress, and we really encourage also other organizations and health authorities to prioritize as well.
Great, Jamie. Thank you.
Sorry, can I just
For
add
those
one
of us who are, I was just
sorry,
going to say, for those of us who are joining a little bit late, I want to just make sure that we introduce ourselves. So welcome everybody to World Humanitarian Day, and our topic today is medical ethics, MSF's duty of care. And we have a great panelist lined up for you today. I'm Saleem Kassam in Toronto, a cardiologist. On the screen, we have Lindsay Bryson, who's joining us from Sweden as the Medical Innovation Unit leader there. And we have Jaime Wah in Windsor, who's leading our COVID-19 response team, both registered nurses, both vast field experience. Lindsay, I'm going to have you comment, and then I wanted to follow up on this topic with a question that came from the audience.
Yeah, sorry, it was just a last thought on what we were talking about, is that I think when we're looking at the resources and how to distribute them the most effectively, I think, we talk very often about material resources, but we have to consider that we don't have the staff in place. Those resources don't take us anywhere. If you don't have the staff who know how to use those resources, we don't get anywhere. So I think it's also really important for us to be to recognize also how that dynamic plays into it. If you can't get any doctors into the location that you're in, then having ventilators may be less useful, or maybe not the strategy you go for. So I think that, again, the HR component is super important.
Yeah, good point. And we know in our current environment, in the hospital setting, for example, unless you know how to manage a certain piece of equipment or a certain process and have the proper protocols in place to support it, it's actually unethical to provide that kind of care, because it wouldn't benefit the patient, and you are taking resources from somewhere else that could be used more effectively. So that's great. There was a question to follow up on this, if I can, because we talked about prevention. We talked about, Lindsay, you talked about where we could have the most impact. One of the questions that came from the online questions that were submitted before was one around prolonging life, and I wanted to just mention that for a moment. It says here, Carolina Merlo from Ecuador asked, what is the most challenging situation you face when deciding what patients might recover or not, taking into account your resources? Our duty as doctors is not deciding who lives or not, it is trying to prolong life. During this pandemic, it seems that resources or lack thereof are making us take those hard choices. Maybe I'll ask, I'll start with Jaime. How do you feel about that? And is our role to prolong life? Is it to make difficult choices around resources?
Yeah, I think I'm not going to speak directly to the COVID right off the bat, but I'll talk about a personal experience that I had in the field. So this was in South Sudan, in a refugee camp in Bentiu. And this was, we were receiving a lot of an influx of new arrivals into the camp, and a lot of, really critically malnourished children, high levels of anemia, malnutrition, and people were just coming really, really late into the hospital. And I remember we had very few nurses and very, very few staff. We didn't have enough hospital beds. And so we were really challenged to, really stretch our resources. And essentially that decision was done with every patient that came in. If we worked on the sickest kid that came in, and then we went to the next one and to the next one. And if a sicker kid came in, we would work on that one until we transfer them to the floor, and then we would to the admission unit. And so we would just continue to, deal with what we have on hand. And so really at the field level, it's really just whatever walks through your door, you're really, taking a look at what their needs are and then making a decision based on, where to put your attention, what's the most you can do. And unfortunately, we did have a lot of children that didn't make it, but we really could not focus on the ones that couldn't make it. You really had to, go on and on with your day and manage the kids that might make it. And they might not make it in the end, but you're still going to try. And it's going to be a lot of work and a lot of effort. But at the end of the day, there was, people that we did save and kids that we did save. So it's really, really hard when you're on the field and having to make those critical decisions. And I think in Canada and in other parts of the world, especially dealing with COVID and these high mortality rates, it's something that we're not so familiar with doing, having to do this kind of critical triage as to where to best reallocate those resources. And I think it's also been challenging for multiple levels of government to kind of come to an understanding of how best to mitigate these risks and how to reallocate those funds and those resources. So, if we take a look at it kind of from an international perspective, we do know that most countries in the Western world are developed. They have, certain things in place and they're able to scale up. And that was the case in Canada, that, the pandemic hasn't overwhelmed our healthcare system. So yeah, those choices are a little bit easier for us versus countries like Italy, and where they had, really, really difficult choices where they're, the sick people kind of overwhelmed the healthcare system. So once you get into those type of scenarios, then you're kind of, seeing what we do kind of in the field, and that's that critical triage and really, all hands on deck and really addressing the most serious cases as fast as you can.
Okay. Good. Yeah, the issue of impact is important. You mentioned it, brought it up, and I suppose it means doing the most good with the limitations that you have. And sometimes when someone is critically ill and you can't make them better, you can still have an impact on providing them with some dignity in the illness they're going through. Great. There's a question that came online that says, it's from Leela Brahimi, if I pronounce that correctly, from Montreal. What is the current state of ethics in relation to medical humanitarian innovations? Lindsay, this is for you.
For me.
How do you how does that play into where you decide to put your energy and efforts?
Yeah, I hope at least MSF has taken the right steps. As we know, we follow generally medical ethics within our research scope. We have an ethical review board, and it's the same for innovation as well. There is a framework for innovation in the humanitarian sector that we try to follow, and that, of course, it's going to be around still patients' autonomy. You're still going to ask people, even in an emergency, can we do this? Do you feel comfortable with this? And of course, that power dynamic is really complicated because things tend to be, moving really quickly, but that needs to be in there. And same as always, not, assuring that we're not going to make the situation worse. And the goal is to decrease harm and to alleviate suffering in the way that we always want to. So I think it's there. Is it followed all the time? I hope so. So I think we're in a good position.
Lindsay, can you give us an example?
Let me think.
Where you've had to make those choices.
Now I'm just going to talk about someone else's project. I hope they don't mind. I think a lot of lessons were learned during the Ebola outbreak, particularly in DRC, around community involvement and how we need to be better at involving the community in the work that we do. And one of the tools that has been created through one of the MSF entities is it's sort of a gamification. So it's an app that people can use, and it teaches people about the disease, and it questions that, it asks them how they feel about it, and it gives certain feedback loops. So this was then brought to first the field project for one who said, we have this problem and we want to see how we can address it in a creative and fun way to try to have a better community engagement. And that was then discussed more broadly with the community before the tool was even brought in, and they helped develop it. So I think it's an innovation within that context in terms of how they were engaging with the community and sharing information.
Very cool.
That answers the question.
Very cool. Yeah, that's great. John Pringle, who might know a thing or two about ethics himself, had a question that he posed to us earlier, and he asked from Belleville, how does MSF resolve ethical conflicts or competing ethical principles? Jaime, why don't you take a stab at this one? I assume competing ethical principles might be things like patient confidentiality versus sort of greater good for the population, or medical care versus right to privacy. I don't know, but can you think of something where you've had to work through that?
Yeah, I actually can. So yeah, I was involved in an Ebola project, and this was kind of towards the end of the Ebola outbreak. And I remember where I was, we were kind of hearing that there was a case that came up, and so we were kind of just trying to track when these cases were coming down. And I can kind of see this happening here as well, as the case numbers slowly come down. And it almost became like, once there was a new case, it almost came like a witch hunt to try to find those cases and to isolate all their contacts and really get on that, because I think the community had come into a good understanding of the risk, and they wanted to really isolate those individuals. And it came to a point where at some point the name and the age of these individuals and their close contacts were made available to the public, and the people were getting mass SMS messages. And then it was like everybody tried to look for these people and try to hunt them down, and people went into hiding, and it was just a really chaotic event. And so, yeah, this had happened. I don't necessarily think that's the best way to go about it. But yeah, I mean, when it comes to these public health emergencies and you're trying to get a handle on the outbreak, a lot of personal privacy and personal information it becomes a gray area, and people's travel restrictions have been, restricted. So our freedoms have been restricted in many cases in these outbreak settings. So, trying to tread lightly onto, what's best for everybody in terms of an outbreak setting versus, the privacy of your own personal information. It becomes kind of this interesting, area to navigate through. So yeah, and each context has its own way of doing it. And so this is why ethics is really, it's really based on that, host society and what's best for everybody in that particular moment based on those decisions that are made. So I can't say in that context whether it was right or wrong, because that's what was decided for the authorities to do, and it managed that outbreak. It got those people into isolation and had people looking for them, and everybody knew. But yeah, it does infringe on privacy, and it does infringe on personal freedoms. So it is a hard decision. So yeah, there's that. It's an unclear answer.
I don't think there is a right answer. Lindsay, do you have anything you'd like to contribute here? Do you have any thoughts?
I think, when we're faced with something like that, the most important, you're going to sit down usually as a team, as a group, and try to work through it. And I think these become often very highly charged discussions, because it really lays bare kind of where people value things. And some people will value things very differently. Some people might think that question of confidentiality in this, that's not even an ethical decision. That's what has to happen. Some people will come at it from that perspective, and others will say, no, this is absolutely needs to be protected. So I think those types of discussions are really, really complicated. And I mean, again, that question of patient autonomy. Someone comes into your hospital. I mean, I've had the unfortunately been faced with, a woman coming in who desperately needs a cesarean section, but says she cannot do it. She cannot consent to it until her husband is there. And the husband's nowhere to be found, and she's, slowly bleeding and will If we don't, lose the baby, we might lose both of them. And how, and as a medic, it's like you're just watching this happen, and you can't believe that this could possibly happen because we can't find this one person in the family who can take this decision and who is not your patient. And I think those we're faced with quite often, that really that patient is refusing life-saving treatment.
Great. Okay, some other questions that have come up. We're going to try and work through some of them. Dennis Punter from Toronto asks, perhaps Lindsay, I'll get back to you on this one, just for the global perspective. How do you ever set priorities with so many diverse countries and needs and relative urgencies?
I mean, I think we've said this a little bit at the beginning, because it's, of course, this is not just about medical ethics, right? I mean, this is, again, taking it within the context and looking, as an organization, we will look at the unmet medical needs in a particular country or a particular region, but we'll also look at the humanitarian context. We'll also look at the people who are on the ground, because maybe there is another actor on the ground who can take on, if not the entirety, maybe just some of the activities, and then we can prioritize where we go. And then at the end, it is looking at how do you then prioritize. And again, I'll go back to it. I'll say it often. I mean, for me, it is about where can we have the, in most cases, I'm not a complete stickler, but where can we have the biggest impact for the highest number of people in that particular context, with all those issues surrounding it. I've certainly also been in projects that it wasn't actually going to be a massive impact, but we knew that if we weren't there, if we weren't able to bear witness to that particular population, who was not very big, and even I could say maybe didn't have massive unmet medical needs, but their humanitarian situation was atrocious. They were, really, really vulnerable. So I think there are still ways to look at the situation, and it's definitely not black and white. It definitely, again, very emotive discussions, people saying where their priorities are, and hopefully at the end coming to a mutual agreement on the best way forward, not the right way forward.
Mm-hmm. That's great. Yeah, it does speak to the fact that sometimes we have to leave situations where we realize, while there are needs there, our ability to impact that has shrunk or vanished. Mm-hmm. And those are situations where we do leave because we can't have the impact that we want to, whether it's a large medical need or not.
Mm-hmm. Yeah, and I think also that we also, it's also, yeah, I agree, the material resources or where we decide to intervene, that plays a big role. But in cases where we can't actually be there or can't actually intervene, oftentimes what we do is we do the advocacy, we speak out, and we bring light to what's actually happening, so that we might not be able to do something, but others might be able to do something. So this is one of the, I think, unique things about MSF is that we will speak up. We're not afraid of speaking up if it's for the greater good. If we see that we can't operate because of certain reasons, but there is a huge vulnerable group there, and those needs are not being met, then yeah, I think one of our strongest tools is our advocacy and speaking up.
Great. Jaime, this question is going to be for you. It comes from Romeo Masood. I'm not sure where he's from, but Romeo asks, where has MSF Canada reached out during COVID-19 outbreak, nationwide and abroad? And what more can we do to help?
Yeah, it's a great question. So yeah, we started thinking about COVID operations in Canada, I think it was late March, and we were kind of putting a team together to look at Canada to see what needs there were in Canada. We've never been operational in Canada, so that was the first time. And we don't have the normal tools that we have in our international operations with the supply chains and things like that. So what we did want to know is whether or not there was urgent needs. And I think what we saw in ourselves was that we have a lot of field workers in Canada that have experience working in outbreak settings, and that what we would be able to support with is kind of sharing our technical expertise and sharing knowledge on how to deal with outbreaks and manage isolation centers and things like that. So what we did, we had somebody in Yellowknife, Montreal, Toronto, and Vancouver, making connections with some of the local organizations, looking at what the vulnerable groups were. So in Montreal, we did some long-term care assessments and for long-term care facilities. In Toronto, we had also some interest in partnering and working with people experiencing homelessness and some of the associations working with that population. We also, we took a look around. At the end, we decided not to continue operations in Canada. We also worked a little bit with Indigenous communities and built some tools to kind of help better shape understanding of infection prevention and control and how to repurpose medical infrastructure. So those tools are now available on our website, and all of the communities can use that, and anyone can access those. But yeah, we've decided to refocus and prioritize the fundraising that we do and the human resources that we have to our international operations. So if you do want to help, definitely there's the COVID Relief Fund that people can donate to. We're still sending field workers to the field for COVID responses. So yeah, there's still lots to get involved in. Although domestically, apart from these kind of online tools that are still going to remain, we've kind of taken a step back as well.
Okay. Great. Well, we have about 10 minutes left. I want to welcome any new viewers to the program today, MSF's Medical Ethics on World Humanitarian Day. So if you are joining us, welcome. Please feel free to ask questions in the chat, and we'll try to get to them in the time remaining. I'll go to the next question that came online from James Gerber in Brampton, who asks, what situations do you find yourselves in where you're pressured into compromising your ethics? Lindsay. Let's start with you.
And maybe it's a tough one, because I think it also goes a little bit on a scale, which may be a funny way of putting it, because we've talked about the examples already where I've been faced with patients who have refused care and struggling with that issue of not wanting to listen to them, but knowing that we have to, right? But other examples I think are also around the quality of care that we're able to offer, that while of course we always strive to provide the best care that we can in any given context, it's not always possible. And it's not always possible because we might not yet have all the materials that we need. It might also be that we're treating a disease that is so neglected that there is no good treatment, and I think if I think back to my very first field assignment, we were treating a disease that was classified this way. And, what were we, 18 years later, we have just in the last 2 years ended up with a very effective oral treatment. But it came from people who were actually having to treat patients with a drug that killed actually a fair percentage of them. It cured people for sure, but it also, we knew that it was a bit of a risk. But that was the WHO standard. That was all we had. And I think that to me is a really great example, because it shows, for one, where we knew we were doing harm. We assumed we were doing a greater good, but we knew we were doing harm, and that was very difficult, but it translated into action. And I think that the action that it translated into, as Jaime said about the bearing witness, it led to clinical trials, it led to a whole lot of work. I mean, the DNDi did an incredible amount of work, and now we have an effective treatment. So I think there's like this whole spectrum and this whole chain that you could follow from when you felt that this is unacceptable. I am having to compromise my ethics, but MSF, I think, has at least the voice and the strength to be able in those types of situations to kind of get over that hurdle and then be able to provide this, again, small population. This is why it's neglected, right? There's not many people who have this particular disease, but we're able to now provide them with very effective, very easy treatment.
Great example of how a difficult situation that compromises your ethics can be used to provide greater benefit on the road. Well done. There's a few more questions we're going to get to, so we'll keep our answers relatively short if we could. Lindsay Joseph from New Westminster, British Columbia says, how do you resolve your commitment to providing healthcare when it comes into conflict with religious cultural beliefs? Jaime.
Yeah, no, I think this is a great question. And it's always a challenge, but I think we also have to take ourselves out of our own shoes and put ourselves into our patients' shoes, because I think coming from, the societies that we come from this idea that, at least in Canada, that healthcare is free and it's accessible to all. And this is not the case in a lot of places. And there's a lot of, differences in religious and cultural beliefs that are very different than in Canada. So I know, for example, going and working in those settings, it might not be what I think is right, but at the same time, that's what they think is right, and that's what's important, is to do no harm. Yeah, so for example, I know we have a lot of you know, about, young pregnancies or, rapes in countries where there's a lot of conflict, there is a lot of rapes. So then having to, do treatment and care around that is very, very sensitive in a lot of areas. And so what we want to do is provide the best care to those women who are victims of sexual violence. But that's a very, very sensitive area because it's tied into religious belief and cultural beliefs. And we really, really have to be sensitive to that. It doesn't matter what I think is right or wrong regarding those. It really is what's the safest thing for this person, and how do we counsel her, and how do we treat her, and how do we, I think in a lot of places it happens quite often, and it's not taken very seriously. And at the end of the day, it is the woman that really does suffer in silence. So to not allow her to suffer in silence, to bear witness to that, but then to also, motivate change, even though a lot of that is it's a very difficult situation. There's a lot of conversations, uncomfortable conversations with a lot of different actors as well. But yeah, it's these things are often the source of a lot of conversations in the projects because it's not an easy answer, but we do, I think at the end of the day, have to do what's right for our clients and what they wish to do. And I think that is the basis of our decision and our what should be done.
Okay.
And whether or not that's legal in the country and not legal in the country, that's a whole nother story. So
great. Tough question to answer in a short period of time. We have just a few minutes left. We have another question from Montreal, and I'll pose it now. With the spread of disinformation via social media, etc., how can we provide care to individuals and communities who distrust medical teams based on this disinformation? Example, claims in parts of Asia that polio vaccine campaigns are rooted in efforts to sterilize specific groups or communities. Lindsay, take a stab at this one?
I mean, it's a tough one, and I maybe it's going to be a bit of a naive answer, but for me and my own personal experience in the field, it has been about our engagement and proximity to the communities. The closer we are and the more we're talking to the people in the community, to the official and unofficial leaders of these communities, getting or trying to establish trust, then those messages, I mean, I've had cases where they've come to us and they've asked us like, hey, we heard about this, what do you guys think? And that was based on a very trusting relationship after many years of us being in that environment and providing care. But I think, again, that's one of the strengths of MSF, to be as much as possible proximate to the populations and engaging with them. And I know we're not always as good as we want to be, but I do think that we're always striving towards that. So for me, disinformation is really difficult. I think we're looking at more digital health promotion tools, looking at different, I mean, I'm not the tech person, but looking at different sort of Facebook channels and WhatsApp groups and all these different things to try to get out the right messages to people. But for me, again, it does come down to proximity and to understand the experience of the population as best as possible.
Great answer. Very good. I think there's I don't see any more chat questions. I think we have just a minute left. It's been a great conversation, difficult topics, hard to get through, no easy answers, sometimes no answers, just directions and struggles we could take. I want to thank you both, Jaime and Lindsay, for participating here today. For those listening, thank you for the questions. Please feel free to watch the YouTube video afterwards, and go to our website and see how you can get involved if you would like to, because there certainly are needs out there that need to be considered. So I appreciate everybody's time and effort today, and your expertise, Lindsay and Jaime. Thank you, everybody, for today. Hopefully we'll do this again sometime.
Thanks, Saleem.
No problem. The website is www.doctorswithoutborders.ca.